Welcome back to the deep dive. Today, we're doing something a little different. We're getting, tactical.
Very tactical.
Yeah, we are stripping it all back for a high-yield revision session. This is for all you plastic surgery residents staring down the barrel of your board exams, especially the FRCS.
That's right. We're cutting out all the fluff. Today is purely about the management of facial soft tissue injuries.
The bread and butter stuff.
Exactly. Lacerations, nerve injuries, duct repairs. But it's also, surprisingly where a lot of candidates trip up on the details.
It's the simple stuff that catches you out, isn't it?
Always.
Because you just assume you know it cold, you'll spend weeks memorizing the blood supply of a free flap, and then you fumble a basic question on lip repair.
Exactly. And look, if you miss a parotid duct injury in the Viva because you didn't check the landmarks, or you propose a surgery that's not indicated, that's an immediate fail. You have to know this stuff perfectly.
So before we even start, I have to be completely direct with everyone listening. We are covering the facts today, the what and the how for your written papers. But if you want to pass the Viva, if you want to survive that intense clinical question,
Yeah, where they're actively trying to trip you up.
right, you need to go get the premium subscription right now.
It really is non-negotiable. The premium feed unlocks the Journal Club and, crucially, the Clinical Cases episodes. That is where you learn to argue your corner.
Today is about the facts.
Premium is about the application and the defense of those facts.
Okay. Consider that your call to action. Now let's get into this. We're going to treat this like a rapid-fire session. I'll throw the scenarios at you. I want the board standard answer, but also the why behind it.
Ready? Let's do it.
Let's start with the basics. General principles, the skin. You're on call, it's 2 a.m., messy facial laceration comes in. What's the philosophy on debridement? Because, in general surgery, they teach cut until it bleeds.
Right. Aggressive debridement is the rule elsewhere. But on the face, you flip that entirely. The rule is minimal debridement.
And why the exception? Is it purely aesthetic?
That's part of it, but it's mostly physiological. The face has this incredibly robust, forgiving vascular supply, just so much redundancy.
Okay.
It means we can preserve tissue that would almost certainly die if it were, say, on the shin. So you only debride what is undeniably necrotic. If it's questionable, you give it the benefit of the doubt.
So just trim the edges for a clean closure and that's it.
That's it. But
Yeah.
there's one thing you must be aggressive about removing.
The hygiene part.
Yes. Dirt, road rash,
Uh,
any kind of grit or foreign body, you have to get it out, and you have to do it immediately.
and that's not just about infection risk, is it? There's a long-term problem here.
It's about traumatic tattooing. It's a total nightmare.
Explain that.
If you leave grit or asphalt in the dermis and the skin heals over it, the body just encapsulates it. You've essentially created a permanent, ugly tattoo.
You can't just laser it off later.
It's incredibly difficult. The particles are often too big or too deep. So minimal tissue debridement, but maximum aggressive cleaning. Scrub it out with a brush if you have to.
Crystal clear. Save the skin, scrub the dirt. Let's move up to the eyelids.
This feels like prime real estate for exam questions.
Oh, it is. The anatomy is so specialized, and the margin for error is basically zero.
So you have a full-thickness laceration through the lid margin. What's the principle for closing that? You can't just throw in a few stitches, right?
Absolutely not. That's an
How do we
immediate
explain?
fail. It requires a layered closure. You have to respect the anatomy, the lamellae.
The layers.
Right. You have to perfectly align the tarsal plate, that's the skeleton of the lid, then the orbicularis muscle, and then the skin. If you get that tarsal plate wrong, you get a notch in the eyelid margin.
And that's not just cosmetic.
No, it causes tearing, exposure issues. It's a functional problem.
What about the inside layer, the conjunctiva? Do we suture that?
Generally, no. And that's a key point. The conjunctiva heals incredibly fast on its own.
So just leave it.
Let it heal by secondary intention. You avoid sutures there because they would be sitting right on the cornea.
Rubbing with every blink. Yeah, causing irritation, abrasions. You want to avoid that at all costs.
Speaking of the cornea, you've done a complex repair, there's swelling, you're worried about the eye drying out. What's the move?
You need to consider a frost suture.
Walk me through that. What is it?
It's a temporary traction suture. You pass a suture through the gray line of the lower lid and tape it up to the forehead.
So you're pulling the lid up.
You're physically suspending the lid in a closed position. It's like a temporary patch, protecting the cornea while the swelling goes down.
A do not disturb sign for the eye. Okay, let's move to the danger zone. The medial canthus.
This is where it gets tricky
Yeah.
and where diagnoses are missed.
So you have a laceration near the nose, looks minor, how do you prove if the lacrimal canaliculus, the tear duct, is cut?
You can't just guess. You have to irrigate. You take saline, you stain it with fluorescein.
The yellow dye.
Right. And you cannulate the punctum, that little drain hole on the lid margin, and you gently push the plunger.
And what are you looking for?
If the system is intact, the dye goes into the nose. If you see yellow dye welling up in the wound, you have a confirmed injury. The plumbing is cut.
Okay, confirmed injury. You're in the OR. Let's do the 4-step repair. Step 1.
Step 1 is visualization. You have to find the two ends. So you dilate the punctum and pass a Bowman probe through it.
Like a little guide wire.
Exactly. It'll pop out of the cut proximal end in the wound, show you right where it is.
Okay, step 2.
Intubation. You have to stent it or it'll scar shut. The classic text answer is a soft silicone stent, like a mini Minoka.
Describe that.
It's a tiny silicone tube. You pass the tail of it through the cut ends, bridging the gap.
Okay. And step 3.
Suture the duct. You're placing very fine sutures in the tissue around that stent, rebuilding the tunnel.
And step 4, the timeline. How long does the patient wear this thing?
It has to stay in long enough for the scar to mature. So the stent typically remains in place for 2 to 3 months.
2 to 3 months. Oh. Got it. Is there anything else we need to check in that medial zone?
Absolutely. The medial canthal ligament. It anchors the whole eyelid to the nose. Mm-hmm. If you fix the duct but miss a detached ligament, the eye drifts outward. You get telecanthus, a major deformity.
Good point. Okay, let's switch gears. Cartilage, specifically the classic contrast, ear versus nose.
A favorite exam question.
Let's start with the ear. Laceration, right through the pinna. Do you have to put sutures in the cartilage itself?
Usually no, and that's the key difference. The skin on the ear is stuck down so tightly to the underlying cartilage
right.
that if you just suture the skin meticulously, the skin itself acts as a splint. It pulls the cartilage into perfect alignment.
So the skin does all the work, but there's a big complication we're trying to avoid here.
The pinna hematoma. We are terrified of it.
Why? What happens?
The ear cartilage is avascular. It gets its nutrients from the overlying skin. If blood collects between them, it lifts the skin off, the cartilage suffocates, and it dies.
Cauliflower ear.
That's how you get cauliflower ear. It crumbles into fibrosis.
So how do we prevent that?
We use through-and-through bolster sutures. You place sutures that go all the way through the ear, front to back, tied over gauze rolls to compress everything and eliminate that dead space.
Okay, what about a total amputation?
If you have the part, microsurgical replantation is the gold standard.
And what if someone suggests just sewing it back on as a composite graft?
The text is pretty clear on this. Most large composite grafts fail. They just don't get enough blood supply by diffusion alone.
Okay, so that's the ear. Now let's contrast that with the nose. Same principle. Can we rely on the skin to align the nasal cartilage?
No, absolutely not. That is the critical distinction.
Why not?
The skin over the nose is thicker, more mobile. It's not stuck down in the same way. Mm-hmm. So suturing the skin is unlikely to restore the cartilage alignment. The cartilage can stay twisted or collapsed underneath.
So for the nose, you have to do what?
You need anatomical restoration and a layered closure. You have to find the cartilage edges, place sutures directly in the cartilage to line it up, then close the soft tissues over it.
A vital distinction. Okay, let's drop down to the lips. What are the 2 critical elements of a lip laceration repair?
1, function. The lip is a sphincter. You need a layered closure to repair the orbicularis oris muscle.
So the patient can seal their lips.
Right. And 2 is aesthetics, specifically the vermilion border, that line between the red of the lip and the skin.
Yeah, get that perfect.
Perfect.
Yeah.
Even a 1 millimeter step off is noticeable at a conversational distance. And a key tip here, you have to mark that border before you inject local anesthetic.
Oh, why is that?
Because the anesthetic distorts the tissue. It swells the lip and blanches the color. The landmark just disappears. If you numb first, you're lost. Mark first, numb second.
Great tip. Okay, let's talk nerves. The facial nerve, high stakes. When do we operate on a sharp division?
The optimal window is within 48 to 72 hours.
Why that specific window? Why not right away or in a week?
It's all about the nerve stimulator. For about 72 hours, the distal stumps of the nerve, the parts cut off from the brain, will still twitch when you stimulate them with electricity.
So you can find them.
You can find them. After 72 hours, Wallerian degeneration sets in. The ends lose their excitability. They won't twitch. It becomes almost impossible to find them.
That's a crucial point. Now, there's a specific anatomical boundary for when we even attempt to repair. Talk about the lateral canthus rule.
Right. This is the medial to the lateral canthus rule. Yeah. You draw a vertical line down from the outer corner of the eye.
Okay.
If the nerve entry is medial to that line, so closer to the nose and mouth, we generally do not attempt to repair.
That seems counterintuitive. The nerve is cut, why not fix it?
Because at that point, the nerve branches are highly arborized.
Mean?
They form a complex, interconnected meshwork, like a spider web. They're too small and too numerous to fix accurately. You'd cause more damage trying.
So what happens? Is the patient just paralyzed there?
No. The good news is that because of that meshwork, there's so much redundancy that most of these injuries undergo spontaneous reinnervation. Function just comes back on its own.
So sometimes the right move is to do nothing.
Exactly. But if there's a gap in the nerve further back, you'll need a nerve graft to bridge it. Schurl nerve is the classic choice.
Okay, last up. The parotid duct. Stenson's duct. Surface anatomy. How do you know if you're near it?
You draw a line from the tragus of the ear to the corner of the mouth. The duct runs in the middle third of that line. An injury there, you have to suspect a duct injury.
And what travels with it?
The buccal branches of the facial nerve. They're travel buddies. If one is cut, you have to check the other.
And if we miss the duct injury, just sew the skin.
Big mistake. The gland keeps making saliva with nowhere to go. You get a xyloscally, collection of spit under the skin, or a salivary fistula, where saliva just leaks out onto the cheek.
Not good. So how do we fix it?
The key is intraoral cannulation. You go inside the mouth, find the opening opposite the second upper molar, and thread a cannula backwards into the duct.
To identify it in the wound.
Yes. And just like the lacrimal system, you repair it over a stent. A 5 French pediatric feeding tube works perfectly.
And how long does that stent stay in?
It's a shorter timeline. About 3 weeks.
3 weeks. Okay. Let's zoom out. Skin, eyes, ears, nose, lips, nerves, ducts. What's the common thread here for a resident studying for their exam?
The common thread is anatomical restoration. It's about knowing the anatomy so well that you can put everything back exactly where it belongs. The vermilion border, the tarsal plate, the cartilage.
And knowing the why, like the contrast between the ear and nose cartilage?
Exactly, and the timelines. 72 hours for the nerve, 3 weeks for the parotid stent, 2 to 3 months for the lacrimal stent. These are just hard facts you have to memorize.
And I think maybe the most provocative point is the decision not to operate.
That's the one. That's what separates the novice from the expert. Knowing that a facial nerve injury medial to the lateral canthus should be left alone, that requires confidence.
Trusting the pathophysiology.
And not causing more harm by digging around. That is a classic Viva trap.
Which brings us right back to where we started. We've given you the facts, the lists, the timelines. But to practice applying that judgment, to see how it plays out in a messy clinical case.
You need the premium feed. You need the clinical cases episodes. That's where we really put you on the spot.
If you're serious about the boards, it's essential.
No question.
Go subscribe. Get the journal club. Get the cases. Ace the Viva. That's our deep dive on facial soft tissue injuries.
Study hard and good luck.